I'm Marielle Wondergem. I work in the VU University Medical Center, Amsterdam, the Netherlands. And we are a referral center for AML patients. Our region is about 4 million people. I work with inpatient and outpatient. And we also perform autologous and allogeneic stem cell transplantations. And a lot of these patients are referred to participate in studies. This patient was also referred to us after she had presented to her GP. She worked in car sales and run the business more or less, and he had never seen her before. And she only complained of tiredness, but because it was the first time he saw her, he thought, I should better take labs. And at that point, he found an anemia of 5.8 millimoles per liter and also a leukocytopenia with 6% of blasts in the peripheral blood. That was the time when she was referred to a hematologist nearby, and he performed a bone marrow examination showing 15% of blasts and a picture of array AP2. And at that point she was referred to us for treatment. Well, the main trigger to send patients to a nearby hospital were the blasts peripherally, because they cannot be explained by a benign disease. So that's why they thought about a myelodysplasia or a leukemia, what had to be the cause of her problem. It's quite often that you don't see much in the peripheral blood, only a few blasts. So she came to our hospital 2 weeks later, and at that moment a bone marrow examination was performed and we counted 21% of blasts. So at that moment it was already acute myeloid leukemia. And her blood counts were unaltered. And what was nice about this case, and that was how I met her, is that you could see some of the molecular findings already looking at cells. Because when you look at this picture, you see an indentation in the nucleus, and we call it a cup-like cell, whereas I always find it more resembling a football that's out of air. But this is typical for an NPM1 mutation. And in this patient we also found a possibly small population with FLT3 ITD mutated cells, but it was smaller than 1%. And her karyotype was normal. I always ask myself, what does this test mean for this single patient? And when we talk about the NPM1 mutation, what it really is a nucleophosmin-1 mutation. It causes aberrant cytoplasmic accumulation of protein, and it causes functional losses in the cell. It's correlated with a normal karyotype. Almost 85% of NPM1 mutated patients have a normal karyotype. And it's a very early mutation. But this patient also had a small population with FLT3 ITD mutated cells, and this is a mutation that is an internal tandem duplication of the FLT3 gene, and it is associated with an increased risk of relapse and inferior overall survival in AML patients. It's a secondary mutation that leads to a proliferation advantage of the cells, and its effect on the whole picture in this patient is also dependent on other mutations. Because when we seek the best treatment for our AML patients, we always do risk assessment. You have the favorable risk, intermediate risk, poor and very poor risk. When we look at this patient, and if we would say the FLT3 ITD mutated population is very small, so she only has an NPM1 mutation, she would be a favorable risk. Whereas if we count in the FLT3 mutation, she becomes an intermediate risk. And that has implications because the second one you would transplant allogeneically in first complete remission. And an allogeneic stem cell transplant is a very intensive treatment that shouldn't be given lightly to people who don't really need it. So when we look at this FLT3 ITD, I always think about the burden because it's only less than 1%. And as in normal life, burden is very important. So what about this burden? What is the meaning for this FLT3 ITD burden for this patient? Well, there have been a lot of investigations, also in NPM1 positive patients, showing that if you have a very small proportion of cells being mutated, and that's translated into an FLT3 ratio, where you have the mutated cells versus the unmutated cells, if that's lower than 0.5 or 1.0 even, that your prognosis is more or less the same as a patient who has an NPM1 mutation only. And if we take into account her white blood cells, she has very low leukocyte count, And if you have a low leukocyte count and a low FLT3 ratio, your prognosis is more or less the same as NPM1 mutated patients. So if we do the sum, she has a leukocytopenia, she has a very low FLT3 ITD ratio, and she is NPM1 positive, and that taken all together means for her a favorable risk. And so we decided not to transplant her upfront. Of course, we wanted to do a very good follow-up to be sure that it was the right decision for this patient. And to do follow-up, MRD is very important. MRD is minimal residual disease, and it can guide your therapy or it can predict a relapse. And we can use immune phenotyping for MRD, but in this case we have two molecular aberrancies that can be used for MRD probably. When we look at the FLT3 ITD, it's not the best candidate because the mutations vary between patients and there are most of the time different clones present at diagnosis and they are unstable over time. Apart from that, it's a secondary mutation, so it doesn't always come back at relapse. Whereas the NPM1 mutation is a much more homogeneous mutation. It has a strong correlation between diagnosis and relapse. It's the same mutation, and we can find it by RT-PCR. So in this case, we could use her NPM1 positivity to detect relapse. And we used this NPM1 positivity in the next years to follow her and to check whether it remained negative. So in our patient, which we treated as a favorable risk due to her FLT3 ITD burden, which was very low, we followed her up on NPM1 and she stayed negative until now. And it has been 3 years ago since I first met her. So in retrospect, it was the right decision. So this 50-year-old lady was diagnosed with an AML and with NPM1 positivity and FLT3 ITD mutation, the last only in a small population of cells, which led us to decide that she was a favorable risk patient and she did not need allogeneic stem cell transplantation in first remission, which is of course very important because an allogeneic stem cell transplantation is a treatment with a lot of morbidity and mortality, which needs investment of the patient, who needs to come to the hospital quite a lot. And we thought with her very low FLT3 ITD burden and her NPM1 negativity after consolidation treatment that we could safely do this for her.